Good evening, everyone, and thank you for joining us. I'm Samantha Winters with PROCEPT Biorobotics and Aquablation Therapy. We're excited to have you here for tonight's webinar, Taking Care of Your Prostate Health, Navigating BPH. We're fortunate to be joined by Dr. James Rybak, a board-certified urologist with over a decade of experience serving patients at Urology of St. Louis. Dr. Rybak is passionate about improving the quality of life for men with BPH, and he's one of the first physicians in the region offering aquablation therapy, a robotic, minimally invasive procedure that's changing the way we treat enlarged prostates. This evening, Dr. Rybak will walk us through what BPH is, common symptoms, how it's diagnosed, and the full range of treatment options, including aquablation. He'll also share patient experience, outline what to expect with the procedure, and answer your questions live. Before we begin, a quick note, your participation tonight is completely anonymous to other attendees. No one can see your name or your face. If you'd like to ask a question, simply type it into the chat box. Your questions will be visible only to Dr. Rybak and myself, and we'll answer them during the Q&A at the end of the session. With that, I'll turn it over to Dr. Rybak.
Thank you, Samantha. Appreciate the introduction. I'm Dr. Rybak. I will be talking with you today about taking control of your prostate health, navigating BPH. Appreciate this being put on from PROCEPT and Helios. This just talks a little bit about me. I'm from Springfield, Illinois originally, did medical school at Southern Illinois and my residency up in Chicago at Rush University. I've been here in the metro region for the last 12 years or so. Samantha already mentioned the disclosures here. So first things first, we're going to talk about some things in regards to BPH. Number one, what is BPH? What are treatment options for men with an enlarged prostate? Why men should consider aquablation treatments, and talk about different patient experiences here. So what is the prostate? The prostate is a gland that is an important gland for reproductive purposes. It primarily is made to make semen. It slowly grows under the influence of the male hormone testosterone. It usually starts growing around the age of 30. While men get older, it causes symptoms. I like to describe the prostate as men get older as a donut, and as the prostate gets bigger, similar to a donut, the donut hole gets smaller, which can restrict the flow of urine and cause lower urinary tract symptoms. Now, BPH is not prostate cancer. That is diagnosed separately. It's a different entity. So BPH is just enlargement of the transition zone of the prostate. Once again, that's that area that obstructs the urine flow from the bladder outside the penis. It's an anatomic disease that requires anatomic treatment. The goal of treatment is to treat the obstructive tissue but maintain the function of the prostate, once again in urinary function but also sexual function. Many men in the United States go untreated due to the side effects of procedures or medications. There's about 40 million men in the United States that have enlargement of the prostate currently. About 6 to 7 million men are on medications. Many may suffer side effects from the dosages. Most commonly, in terms of the side effects of medications, they can be either blood pressure related, they may have runny nose, lightheadedness, dizziness, or they can have sexual side effects that are unfavorable. So that's where you see the pharmaceutical fallout, where about 1 million men will drop off medications and delay treatments despite medication failures. About 400,000 men in the United States undergo surgery every year. Most men, 83%, are not willing to sacrifice sexual function for symptom relief. So what are some of these urinary symptoms due to enlargement of the prostate? One is the ability to hold urine, so men may start complaining to me or one of my other colleagues of, they're getting up 2, 3, 4, 5 times a night. It interrupts their sleep, and they have poor quality sleep because they need to get up and use the restroom more frequently. Sometimes they'll have more symptoms throughout the day, such as the frequent or urgent need to go to the restroom right now. And as the symptoms progress, left untreated, sometimes they'll experience incontinence of urine where they leak because they get that urge and cannot make it to the restroom on time. Some men will have symptoms that also involve the emptying of the bladder. So they may experience a real weak stream or a stream that stops and starts. They may feel the need to strain or push to urinate, or, in some extreme scenarios, they may go into complete urinary retention where they cannot void and need to have a catheter placed. 99% of men with BPH will say, it really impacts their quality of life because it interrupts their sleep, it limits their activities, or they may experience sexual dysfunction related to medical management. So how do we diagnose BPH? In terms of what BPH is once again benign prostate hyperplasia or enlargement of your prostate. We use what's called the IPSS, which is the International Prostate Symptom Score. It's basically a score that gives us an idea, an insight into what a man's urinary symptoms currently are. So a score of 0 to 7 points is mild symptoms, generally well controlled, not needing any medications. Moderate symptoms start to get bothersome. A lot of men in that situation are on or need to consider medications or more, depending upon their bother. And then a score of 20 to 35 points puts them in the red category, or severe symptoms. And we want to know where men fall along that symptom continuum because, once again, it can be bothersome to their quality of life, and we want to know if they'd be happy spending the rest of their life in their current symptom score. So this is a kind of a anatomical picture of showing what BPH is. It's a chronic disease with long-term consequences if left untreated. I like to use the analogy, the bladder is a pump. It's pumping through the prostate. As the prostate gets bigger, the bladder muscle has to get thicker. And as this illustrates, starting on the left side there with a healthy bladder, as the prostate gets bigger and causes more obstruction, the bladder has to get thicker and stronger to kind of push through that obstruction. And left untreated, the bladder will become an inefficient pump and lose function. And sometimes that can lead to permanent bladder damage that can be irreversible. So some of the long-term consequences of that can be bladder damage, the need to catheterize the bladder. Stones can develop in the bladder from incomplete bladder emptying. Men may experience blood in the urine or more frequent urinary tract infections, or even in worst-case scenario, it can cause backup of urine into the kidneys, which can lead to kidney failure. So, the moral of this slide is that watchful waiting can lead to permanent bladder damage if the symptoms are left untreated. Treatment options, there are a wide spectrum of treatment options. Once again, going back to the International Prostate Symptom Score, mild to moderate symptoms, watchful waiting. If somebody has no significant symptoms, then, watchful waiting would be indicated. There's no immediate symptom relief. However, as the prostate continues to grow, symptoms may worsen over time, which can cause bladder damage. Generally first line of treatment is going to be medications to help with symptom relief. But once again, circling back to those side effects, most commonly we'll see dizziness, lightheadedness, headaches, decreased energy, libido changes, or erectile and sexual dysfunction. And over time, the drugs may lose effectiveness. Moving along the continuum, we will talk with folks if the medications fail or they're unable to tolerate them, that there are minimally invasive surgical therapies that can be considered. Most of those are kind of same-day types of surgeries. Some of them you need to stay in the hospital overnight. Some of the minimally invasive therapies that are currently on the market include other treatments, such as going in and opening up the prostate with a laser, putting in little implants to open up the prostate, using steam-based treatments to open up the prostate. But some of those are limited in terms of prostate shape, size, prostate volume, and then also long-term symptom goal and symptom relief. Some of those are more of a temporizing treatment, whereas some of the more traditional, more invasive surgeries, such as more invasive laser therapies or the gold standard, which was once considered a TURP, to go in and do a scraping of the prostate, or a rotor-rooter, some guys will say, to de-obstruct the prostate. Those can have some long-term symptom relief. However, you have to stay in the hospital overnight, and there are rates of irreversible sexual complications and small risk of incontinence. And, I tell folks who are going down that route, in terms of those surgical therapies, the more invasive ones, I would expect for them to no longer have any ejaculation come out after going in and doing the traditional transurethral resection of the prostate surgery. This is just, once again, showing kind of the symptom trade-off and sexual side effects. If you were to ask men kind of their goals, they want most men are going to want BPH surgery that requires a trade-off between, preserving sexual function and effective symptom relief. If you were to ask them, most men are not willing to sacrifice their sexual function and rather deal with, ongoing urinary symptoms than put the risk of sexual dysfunction at risk. Once again, circling back with what we discussed a little bit earlier, 99% of men will tell you that that their enlarged prostate symptoms do impact their quality of life. This is in our American Urologic Association guidelines, talking about shared decision-making. Whenever we're talking with patients regarding therapies, we want to use evidence-based management of their symptoms. We're talking about minimally invasive surgical treatments using newer techniques and treatments. The panel, recommends that the guidelines be followed. And if somebody is in the community and doesn't have access to certain equipment, certain technology, the patients should be engaged with their clinicians to talk about treatment options that are available to help their symptoms. And if that physician is unable to utilize that technology, then a referral to a clinician who has that treatment modality is indicated. And I like to talk to patients about all the options that are potentially available, and if there's something that they are interested in and that I don't offer or I'm not trained in, then I will try and get them to the appropriate provider who offers that service. In all instances, patients will be provided with a risk-benefit profile for all the treatments in light of their circumstances, once again, weighing their urinary function and desire to, preserve sexual function, and long-term symptom goals and symptom relief goals should be kept in light. Generally for our workup with men with ongoing urinary symptoms, I will generally see them and have an assessment of their general health, their history and physical, what kind of medications they're taking, their prior surgical history, how well their bladder is emptying with that International Prostate Symptom Score. The PVR stands for a post-void residual, making sure they're emptying their bladders appropriately. Additionally, we want to rule out any ongoing urinary tract infections, so we assess their urinalysis. We start them on medications if they have not been started on them already, and then we want to reassess their symptoms and side effects if they haven't been on meds or have been on meds. If they have ongoing issues with PSA, the PSA is a blood test we utilize to screen for prostate cancer. We want to obviously rule out prostate cancer before making a diagnosis of someone having BPH. Generally, we will get a flow test to check their flow, to assess their bladder health. And then if their symptoms aren't relieved, we will consider going on into a more invasive approach with office-based diagnostic studies to get prostate volume, which that TRUST stands for a transrectal ultrasound, and cystoscopy to take a look in the bladder to make sure there's nothing else going on and get a better idea of what their bladder health looks like. Medical treatment failure and side effects from other meds, we always want to then, proceed with other counseling based upon that. And then, the AUA guidelines also recommend for patients who have kidney damage due to BPH, or if they're having ongoing multiple urinary tract infections, or they have bladder stones, or they have ongoing blood in the urine from having a large prostate, or their symptoms are just not getting better with medications, then surgical therapies are indicated. Talking a little bit about my experience in terms of the aquablation therapy. This slide is just showing, the majority of these procedures take less than an hour regardless of prostate size. So anywhere from 30-gram glands up over 100-gram glands. Once again, this is just showing less than an hour for the whole surgical procedure. So what is aquablation therapy? Aquablation therapy is a treatment that is intended to provide long-term symptom relief while intending to try to preserve sexual function and continence in prostates of all shapes and sizes. It is a newer technique. Over 50,000 patients have been treated. It has low rates of irreversible side effects, and basically when you're doing the procedure, you're using a high-pressure water jet to remove prostate tissue with robotic assistance. The old therapy, the TURP or the Roto-Rooter, the transurethral resection of the prostate, is a 100-year-old technique. It does have higher rates of irreversible complications such as ejaculatory dysfunction, sexual side effects, and a higher risk of incontinence. The amount of tissue you remove is based off what you see, whereas the aquablation treatment, you're removing tissue based off of not only what you can see, but also image guidance from the ultrasound and the robot. The TURP is fully surgeon dependent, and different surgeons have different outcomes. In terms of symptom improvement, if you look at the large studies on aquablation, most men on average will have about a 16-point improvement in their international prostate symptom score. Low retreatment rates. In terms of retreatment rates in 5 years, it's about 5% in 5 years. So I'll quote patients, usually it's about 1% per year will need some other form of treatment, whereas the other treatments that are available tend to have higher retreatment rates in that same 5-year time frame. Talking about safety compared to other procedures, it has very, very good safety record, and in terms of complications, it's similar to other treatments. In terms of aquablation therapy, it's obviously been proven safe and effective in multiple clinical studies. 99% of men or more preserve their erectile and orgasmic function, their desire, and intercourse satisfaction. About 90% of men will preserve normal ejaculatory function with aquablation therapy, and nearly 100% of men will maintain their continence, and so they avoid that leakage risk that is certainly higher with some of the other therapies that I mentioned. Like I said, 5-year retreatment rate in that 5 to 6% range, whereas other therapies are somewhat higher. So aquablation is a game changer because the robotic assistance and the real-time image guidance that you're using with just using the mechanical energy of water is very, very helpful because you avoid some of the risks of thermal damage with the other therapies. You're using real-time ultrasound combined with the scope through the urinary tract that provides real-time multi-dimensional view, allowing you to see how much tissue you want to remove. Once again, that individualizes it for each patient. Everyone has differing anatomy, and This is where we go down to the next step where it's personalized. The treatment planning is personalized to that man's anatomy, and you map the areas and identify tissues to protect areas such as ejaculatory function and remove the obstructive tissue that is causing the ongoing urinary symptoms. The robotic-assisted execution allows you to do this with that high-pressure water jet to plan and get precise tissue removal. The heat-free water jet, once again, that's just using room temperature saline, which at a high pressure removes the prostate tissue, minimizes thermal spread and damage to surrounding tissue, specifically nerves that are involved with sexual function and continence. So the aquablation therapy is the only ultrasound-guided robotic-assisted heat-free water jet treatment for BPH currently. So this is how it works. So basically, while a man is under anesthesia, we do real-time surgical planning with the help of an ultrasound. This picture is showing an ultrasound of the prostate. We create a resection map, and we find areas that we want to protect. We want to protect areas such as the bladder neck and protect areas responsible for sexual function, but then we want to remove that tissue that is once again blocking the flow of urine and leading to ongoing urinary symptoms. So this is a video showing kind of the ongoing treatment plan in the operating room, mapping out the treatment areas. Once again, individualizing it for that patient. This is another illustration showing what we are actually doing in the operating room while a man's under anesthesia. We will use the robotic-assisted heat-free water jet to follow that predefined treatment plan that we made and resect the obstructive prostate tissue and protect areas responsible for sexual function and continence. So this technology, it really helps us ensure precise, consistent, predictable removal of prostate tissue under real-time image guidance, and we are able to see what we're wanting to remove and what we want to keep and protect. So this illustration is just showing that high-pressure water jet removing that tissue and kind of what we see as the surgeons in the ultrasound, and it's just de-obstructing that tissue. That's the view through the cystoscope, once again showing that high-pressure water jet just removing that tissue. And we open up a nice cavity in that prostate, so a nice channel for the urine to pass with low resistance. Generally, we'll do 2 passes to open up that channel, and then we'll go in at the end and do a little spot cautery at the bladder neck to try and prevent any bleeding complications. So what to expect after aquablation therapy? As with most BPH procedures, I will tell men, you're going to wake up with having a catheter in the bladder. Most folks stay overnight. Some folks can be discharged the same day. I generally will leave a catheter in men at least overnight. During the first few weeks while they're healing up, they may experience some kind of irritative urinary symptoms where it might burn or it might have a stronger urge to urinate while that lining is healing up. Usually folks are back to doing their normal activities within about 2 weeks. And once again, it kind of depends, though, on other medical conditions and other medications in terms of how quickly someone's going to return back to their normal activity. Usually I'll see men about a month or so after their treatment, and if they're on medications, my goal is to have them discontinue those medications by that time frame. So in terms of the journey of BPH, we talked about some of these aspects: watchful waiting, medications, some minimally invasive treatments, the traditional prostate surgery. The aquablation therapy is, unique in that you're able to offer kind of the same symptom relief as the most advanced, traditional prostate surgery. However, you're able to offer the benefits of some of the minimally invasive approaches in terms of preserving sexual function, and getting men off medications, and avoiding some of the complications of sexual dysfunction that can be associated with the more invasive surgical therapies. Once again, it's individualized and been studied and been utilized in a wide array of prostates, ranging from smaller obstructive prostates to really large obstructive prostates. So this is just a slide based off of the disclosure from the PROCEPT. Aquablation is performed by a urologist. Once again, you should be screened by a urologist to determine if it's the right treatment for you. And here are a list of some references. Thank you very much. I'll be happy to answer any questions.
Yes, thank you so much, Dr. Rybak. If you have questions, please feel free to type them in the chat box. What are the qualifications for Medicare coverage?
That's a good question. There used to be a lot more restrictions, but now it's basically, you have to have an ongoing diagnosis of BPH, and you need to, meet certain criteria, make sure you don't have an active urinary tract infection, and, know what your symptoms are, and have a good idea what your bladder health is. But if a man has Medicare, it is a covered procedure as long as it's been appropriately worked up and diagnosed. It is a excellent treatment. I've done this procedure on men from the ages of 50 all the way up to 92, and a vast majority of patients with BPH are covered by Medicare.
And another insurance question, general cost of the procedure, and is it covered by most insurances?
I don't know what the exact cost is. It is a covered procedure. I haven't had any issues with coverage from any insurance providers. As long as you have the appropriate workup and diagnosis, it is a generally covered procedure. Once again, for some of the newer therapies that are out there, if you don't have the appropriate workup, then sometimes it can be challenging with coverage. But if you do the appropriate workup and have all of your ducks in a row, then it is a covered procedure. And in my opinion, it should be considered almost the standard of care for men with BPH.
Yes, and to add to that, 95% of men's lives are covered. So as Dr. Rybak said, he'll do the workup, and it's very likely that your insurance will cover it. Another question, can you use the information already gathered from other doctors in your group to determine if this is a solution for me? I have already been through so many tests and medications.
Yeah. I mean, if somebody has already had a prior workup and has been on medical therapy, and seen other physicians, generally a lot of that evaluation can be utilized and obviously does not need to be repeated. I personally do like to take a look in someone's bladder just for my own knowledge prior to operating on someone, just so I have a game plan of how to address that person's prostate and knowing where other anatomic landmarks are, so that way I don't have any surprises when I do an operation. But generally, if all the other evaluations have been done, I'm not necessarily going to want to repeat those.
Okay. Do all doctors at Urology of St. Louis perform aquablation?
No, they do not. I think currently it's just me and one other physician that are performing the aquablation therapy.
Have there been complaints of pain throughout and post-procedure?
The complaints of pain have been very minimal. Most men, in my experience, currently will just have some mild burning sensation for a few days, but nothing that's really required pain medications more than Tylenol or ibuprofen. Since we're using heat-free water, there's not a lot of pain or discomfort in the postoperative period.
And we've gotten a few of these. Can you explain the difference between PAE and aquablation therapy? And how does a patient's median lobe factor in with either of those treatments?
Yeah, so good question. So PAE is done by an interventional radiologist. It is a great procedure for large prostates as well. The advantage for that is you are not needing to undergo a general anesthetic. It's generally going to be more effective for larger glands. So if a man has a small gland or has an obstructive median lobe, it tends to be less effective. In terms of aquablation, yes, for aquablation, we can plan out the median lobe and remove that at the time of treatment, and the water jet works very well at removing that tissue. And that's circling back to my own having a roadmap prior to surgery. That's why I prefer to take a look in someone's bladder and kind of know their anatomy before. So it helps with my kind of quarterbacking and game planning for that individual. But yeah, circling back with prostate embolization, it is a great therapy. Sometimes it does fail. The advantage of it is you don't need a general anesthesia. The aquablation treatment, you certainly do need to have a general anesthetic. PAE, you don't need to stay in the hospital, whereas aquablation, you have to stay in the hospital, you have to have a catheter. PAE, you don't need a catheter. It's something that, I will talk with my patients about, and, we go over the pros and cons of each approach, and it comes back to that shared decision-making where, I talk to patients, and obviously I'm not an interventional radiologist, so I can't do that procedure, but if I feel like it's indicated, I will refer them to an interventional radiologist to have that therapy done if it aligns with that patient's goals.
If patients have aquablation therapy, are they able to come off their medications?
That is my goal for patients. And in my experience, about 95% of my patients who've had aquablation have been able to come off of their medications.
It was previously recommended that I do the UroLift procedure. Would this be considered something similar?
It's similar, but it is, in terms of durability, it's more definitive because you're removing tissue. The other therapy, you're opening the prostate, and it's being held open by the clips. But the downside of that therapy is that men are more likely to require another treatment in their lifetime. The UroLift is a procedure that's indicated, and it's limited to prostate size and volume. And the aquablation doesn't have the same limitations. I've done a lot of these treatments on men who have had prior UroLifts. So if you've had prior prostate surgeries, this treatment still is indicated for men who've failed other treatments. So, it's one of those things that comes back to shared decision-making. I'll talk with patients regarding that and, tell them about the different minimally invasive therapies, and once again, allow them and me to kind of come to a combined approach to manage their BPH.
How severe are the side effects afterwards, and what are some of the most common ones you hear of?
Yeah, that's a good question. I mean, most commonly, the side effects are very minimal. The most common ones I'll experience in my patient population is the burning on urination and the urgency to go, at least initially, for the first couple weeks, tends to be the most common things I see from folks when they get that urge to go. Since the prostate's now been, de-obstructed, they can't hold it for an extra 5-10 minutes. When they get the urge to go, they got to go now. Obviously, that will generally improve in the first couple weeks while things are healing up, but that's the most common ones I will see in the perioperative, postoperative period.
Can this be done without anesthesia?
It cannot be done without anesthesia. It has to be done under a general anesthetic.
At 56 years old, is it possible that this could be a long-term treatment, or would I have to plan outside of that 5-year potential improvement?
Well, I counsel patients and tell them, that the data on this is only, matured for that many years because this treatment hasn't been out for 20, 30 years. However, you can kind of take a guesstimate and say, well, if you're doing well after 5 years, you can try and suggest that it would probably be, fairly effective 10, 15 years down the line as well. We just don't have the studies to prove that. But I will tell men, yes, I would anticipate it would be similar to having a TURP procedure in terms of its durability. So if you're in your 50s, the goal would be for it to last kind of indefinitely.
How does the instrument get from your urethra into prostate tissue?
So good question. I get asked that question a lot. So once again, I will use the analogy. I'll go back here, and I like to use pictures because they're better than me just discussing things. So the bladder is on the far left there, and the prostate there sits in the middle. And so the bladder sits on top of the prostate, and the urine goes right through the middle of the prostate. And that's where that donut analogy comes into effect, whereas as the prostate gets bigger, the donut hole gets smaller. So we're going in with the scope through the penis, and it's contiguous with the prostate until it gets into the bladder, and that's called the prostatic urethra. And so we're just going through the middle of the prostate into the bladder, and so we're opening up that channel, and that's how we get into the prostate. We're not making any incisions. We're just going in through your body's natural openings.
If a person has already had a TURP or a urolift and are still experiencing symptoms, is the aquablation procedure recommended?
It can be. Once again, it's one of those things where we would want to do an evaluation to see what the source of the symptoms are. But yes, I've had folks that have had prior surgical therapies, laser treatments, urolift, steam treatments, TURPs, and they've had significant prostatic regrowth, and I've done the aquablation therapy on those patients with great results.
I've had a urolift procedure with no success. What's the success rate of this procedure?
Well, once again, it goes back to the evaluation and the confirming the correct diagnosis. So if somebody's had a prior treatment, I will generally start off from the initial workup and see and try and assess where their symptoms are coming from and make sure it's a prostate problem, not a bladder problem, or some other medical issue that is causing their ongoing symptoms. And if it indeed is a prostate issue and the urolift or other surgical therapy didn't work, the aquablation therapy, in my experience, has been similar to the published studies in terms of symptom improvement, on average about a 16-point improvement in their international prostate symptom score. So Once again, it varies from patient to patient, but if the diagnosis and the symptoms are there and the prior treatments were effective or ineffective, this does offer a long-term solution.
Can you share a typical patient experience with this therapy?
Yeah, I mean, in terms of the typical experience is, most of these patients have been on medication for years, have worsening symptoms, have seen either me or seen another urologist, and they're just tired of the medications or the side effects. And we go in and we do an evaluation. We measure their symptom score. We get a flow test. We see how big their prostate is. We counsel them on the different management options. We come to a shared decision-making process. And the aquablation, we get a date for surgery. They undergo the surgery. They generally will stay in the hospital overnight. Once again, the procedure is only about a 1-hour procedure, and that's kind of regardless of prostate size. It's as short as 30 minutes or so. Most of them are going to be about 45 minutes, thereabouts. And they'll wake up with a catheter. We'll get them something to eat, and then they'll stay in the hospital usually overnight with a catheter. I try and get the catheter out first thing in the morning. The next morning, I leave the catheter on irrigation overnight, usually to prevent any bleeding complications or blood clots from building up in the bladder that would necessitate a trip back to the operating room or something along those lines. But my goal is for patients, and the typical experience is 1 night in the hospital, get the catheter out. They tend to have a little bit of urgency, frequency, a little bit of burning for about 7 to 10 days, and then I will usually see them about a month thereafter. That's kind of the typical experience. And then, if they were on medications, my goal by that 1 month time frame is to get them off their medications moving forward.
Can I have this procedure if I'm on blood thinners?
You can have it on a baby aspirin, but if you're on other blood thinners for other medical conditions, then it's one of those things that it depends on the diagnosis of why you're on a blood thinner and whether or not you're able to come off of it safely for a few days.
Is this effective for lateral and medial lobe hyperplasia?
It's successful for all shapes and sizes of prostate tissue because it's customized to that patient's anatomy. And so it's part of our image guidance and the robotic water jet treatment. We will individualize what we need to remove, whether it be just lateral lobes or if it's median lobes. It's all kind of customized during the treatment plan, and it's unique to that patient.
I've always wondered why urgency and frequency are BPH symptoms since the flow is impeded. Is it a nerve stimulation that causes those symptoms?
It can be multifactorial. A lot of times, it's the chicken or the egg. I will tell patients, the urgency and frequency tend to be more bladder symptoms as the prostate gets larger and the bladder itself has to work harder. The bladder muscle loses some of its storage capacity and some of its elasticity, and so you're not able to store as much, and the thicker muscle gets more irritable. So when you reach a certain fullness in the bladder, it will give men the strong urge to go. Once again, that can also be influenced by diet, dietary things, caffeine, soda intake. It can be influenced by diuretics and other medical conditions as well. So it's not necessarily a one-size-fits-all characterization, but a lot of times those urgency frequency symptoms are or can be a component of the enlarged prostate combined with that weak stream because the bladder is working harder.
What kind of facility is this procedure performed in?
It is performed currently in the hospital where folks, like I said, will stay overnight and generally go home the next day.
What if I've been told that I have intravesical tissue?
Once again, that if you have intravesical tissue, that's just part of what we plan to treat. If, for some other of the minimally invasive treatments, sometimes having that anatomy can be a challenge for certain minimally invasive treatments because if you know that's there, it's just going to decrease your success rate for some of the other treatments that are on the market. But if it all comes back to just having a preoperative game plan and having anatomy and knowing what you're wanting to remove and having a roadmap, so to speak. But if someone has intravesical tissue, it's just part of where you plan and you're able to treat that with the water jet as well.
Do you have to go through medical treatment first?
In my experience, sometimes some men, it can be a prerequisite for certain insurance providers, some not. So the answer is it depends. But yeah, some insurance companies and providers will require step therapy and make sure that somebody's failed medical treatment or had side effects from medical treatment prior to covering a surgical procedure.
Okay, thank you so much, Dr. Rybak. If there are no other questions, you guys can go to stlurology.com to find out more information about BPH, aquablation, and other procedures that Urology of St. Louis is offering. We will also send a follow-up email to all of the registrants.